So, dear colleagues, good morning. It's my pleasure to introduce you. Yanina Quito is a third-year resident here in our hospital, and she will talk today about the theme Ileus.
So thank you very much, Stefan, for your introduction. Today it's my pleasure to give you a lecture on the topic Ileus, which is a very common suspected diagnosis in our daily praxis, as we see it regularly in the emergency department or in other medical wards when it comes to consultations. So it's very important to be well informed about it, and just give me a quick outline what I'm going to talk about, and then we just start right away. First, I want to define the word Ileus for you, do some classification together with pathophysiology, talk about the mechanical ileus, and have a focus on adhesive small bowel obstruction, as well on the functional ileus, in specific the postoperative ileus. And then we come to questions and discussion. So the definition of the word ileus comes from the Greek ileus, which means intestinal obstruction. And in German-speaking countries, when we talk about ileus, we mostly refer to the mechanical ileus, which is, as the word already says, a mechanical disorder or a mechanical stop of the intestinal passage, or the functional ileus, which is a motility disorder. The mechanical ileus can be subdivided into the complete or incomplete ileus, which we also refer to as subileus, or, according to location, in small bowel obstruction or large bowel obstruction. So we want to start off by talking about the mechanical ileus. It's found in 20% in the large bowel, caused by malignoma such as CRC, recurrent diverticulitis, volvulus hernia or others, and consequently in 80% in the small bowel. Mostly caused by adhesions, so that is the reason why I want to talk about it later. And this is then called adhesive small bowel obstruction, or ASBO. Other reasons for small bowel obstructions are Crohn's disease, neoplasia, intersuption, volvulus, mostly found in younger children, foreign bodies such as gallstones, tuberculosis or parasitic infections, mostly found in third world. So, but 70% of small bowel obstructions are caused by adhesions, which are caused by prior surgery. So let me give you a quick overview about the pathophysiology. According to location, the pathophysiology differs a lot, but in every location, if the ileus is not treated properly, it will end up in multi-organ failure. When it comes to small bowel obstruction, vomiting is the most often finding, and though hypovolemia is a common cause, which can be followed by acute kidney failure and hypovolemic shock. In the distal small bowel, we will have a transmigration of bacteria from the large bowel, causing a damage of the mucosal barrier and ending up in sepsis or multi-organ failure. When it comes to strangulation or ischemia, the transmigration of bacteria throughout the bowel wall will cause peritonitis. And in the large bowel, we have a really large distended bowel. So this will cause the intra-abdominal pressure to rise, the diaphragm to move more cranial, which will cause a reduced cardiac filling. The cardiac output will be lowered, causing hypovolemia, tachycardia, and respiratory insufficiency. As the pathophysiology is depending on the location, though are the symptoms. When we talk about small bowel obstruction, we see a patient with an acute onset with vomiting and cramps, and the more proximal the process is, the more vomiting of undigested food will occur. But stool and wind conditions may occur delayed, and in the beginning may still happen. And when we talk about large bowel obstruction, except for sigma volvulus, this is also very acute onset, but it's normally long story, but often positive medical history of stool habits and wind habits and increasing constipation. And clinically, we will find a patient with distended abdomen, cramps, and as I said before, stool and wind resistance in the foreground. When it comes to auscultation, we have to be aware of that the end stage of the mechanical ileus will have no bowel sounds. So when we see a rather sick patient with a guarded abdomen and peritonism, we have to be aware that this can be end stage mechanical ileus, and don't be mistaken, that is a paralytic one. So, as I already said, the most small bowel obstructions are caused by adhesions up to 75%. So let's have a closer look on them. Adhesions can be found nearly everywhere in the abdomen, and they can have various forms, as we can see here, string-like adhesion, or like a really large adhesion where bowel is trapped inside and is dislocated to the abdominal wall. Let's have a quick view on pathophysiology. Adhesions are mostly caused by two reasons, which is bleeding or inflammation. Because of that, the coagulation cascade will be activated and a stable fibrin matrix will be formed. And either there's complete fibrinolysis and no adhesions will develop, or there will be migration of fibroblasts, collagen matrix will be formed, and in the end, adhesions. So adhesions are acquired and have various forms, as I said before, and the formation begins shortly after surgery within the first hours and will be most extensive after 10 to 14 days. And the most extreme form of adhesions are those matting adhesions, which are found between every bowel loop, and therefore the surgery is very complicated afterwards. What is the epidemiology and what are the risk factors for adhesions? Actually, 5.7% of readmissions directly after surgeries are caused by adhesions. And most consequently, the more damage is done during the surgery, the more adhesions will develop, as they are caused by inflammation and bleeding. Though open surgery has a much higher risk than minimal invasive surgery, and low abdomen surgery has the highest risk when performed open. As well as previous laparotomies within the last 5 years, or multiple laparotomies within the patient history, emergency surgery, and gallstone spillage during cholecystectomy, which is a very important factor for us to remember. When we do cholecystectomy, it's very important to get the gallbladder out in once and do not damage it during the cholecystectomy. There's the study from the University Hospital in Norway where 500 patients have been examined over a period of 34 years and have been followed up by 10 to 40 years. And they found out that actually with 1 to 3 operations, the risk for adhesive small bowel obstruction rises. And within the first 5 years, one will have the highest risk for adhesions. In their patient collective appendectomy and gynecological operations have the highest risk, but one has to be aware that they will not happen at the same time. As you can see here, the appendectomy has a median of 2 years after initial surgery and gynecological operations after 7 years. And once one had an adhesive small bowel obstruction, it's more likely to get a new phase or like a recurrence. So with more numbers of adhesive small bowel obstruction admissions, the more likely it is to get a new one. So there is a diagnostic algorithm which is described in the Bologna guidelines. And I just want to show it to you. First, we do the initial evaluation with patient history, ask for previous laparotomies or surgeries, do the physical examination and the lab studies, in which we ask for inflammation values, electrolytes, kidney function tests, liver and pancreas values, because pancreatitis is often cause for paralytic ileus, and go for coagulation and blood gas analysis. When we have a very high suspect that this is not an ASBO, but a constipation, then we can go for abdominal X-ray. But when we see there are multiple air fluid levels or distended small bowel loops and no gas in the colon, this should make us suspicious that it could be an ASBO, and then we should aim for CT scan. When we see in the CT scan red flags such as strangulation, ischemia or peritonitis, this is an emergency surgery indication, so the patient has to go to emergency surgery directly, and this will be seen in 20 to 30% of patients. Otherwise, we can go for a conservative trial by applying gastrografin. The abdominal ultrasound has not a high value in the diagnostic algorithm, as just in the early phase one can see distension and peristalsis as well as free fluid, but in the later phases due to gas overlay you can't see much anymore. And the abdominal MRI is just for patients that have a contraindication CT or iodine contrast. So the CT scan, as I already said, is the gold standard for diagnostic. as it can rule out complete obstruction and intestinal ischemia by very high sensitivity and specificity. This is just an example for strangulation. Here you can see a simple loop obstruction, which may be treated conservatively, and here you will see a closed loop obstruction. The closed loop obstruction would be an emergency surgery because the veins are infarctated there. And what you can see in CT scan is this odd conformation of loops, mesenterial edema, or 2 points of obstruction seen here. And here you will see lots of gas bubbles in the small intestine due to bacterial overgrowth from the large intestine. It's also called the small bowel feces sign. So how going we treat the patient? According to Bologna guidelines, after we made the CT diagnosis of small bowel obstruction, we rule out the red flags. If there are red flags, we aim for emergency surgery directly. If not, we aim for conservative treatment. When it comes to emergency surgery, there's always the question whether to do it open or laparoscopically. This is like very small patient collective that can get laparoscopic surgery, and this is only when there are 3 points, like single strang adhesion, less than 2 laparotomies in history, and sufficient experience of the surgeon. Otherwise, the risk to injure bowel is very high, and this causes a higher mortality and morbidity. When we aim for conservative treatment, we have to put a nasogastrial or intestinal tube, do fluid resuscitation, electrolyte correction, and observe the patient critically in our surgical ward. When we apply oral contrast, and the contrast is within 24 hours in the colon, we can start refeeding and send the patient home. If not, or there's following symptoms as persistent ileus more than 72 hours, drainage volume higher than 500 milliliter, CRP rising higher than 75 milligram per liter, or white blood cell count over 10,000, or there is free intraperitoneal fluid on CT, we should rethink our decision and aim for surgery on second hand. So in former days, there was the saying, never let the sun rise over an intestinal obstruction. Well, there have been several meta-analyses about the conservative treatment and the duration of conservative treatment. And actually, the delay of more than 3 days will have an increased risk for bowel resection, up to 30%. And delay of 5 days will have a higher risk of operation, impaired bowel function, and causing higher mortality and morbidity. So how many sunsets are allowed? Actually, we say more than 3 times. Never let the sun rise more than 3 times over an intestinal obstruction. The role of gastrografin as therapeutic approach is doubted. There are some meta-analyses saying that it's a good thing to give gastrografin, and this has a high value, and there's Michael Scotti et al. Saying in 2019 it's not a good option. B. Branco et al. Saying that it has a very high sensitivity in ruling out SBO, or predicting the resolution of the SBO, and reducing the need for surgery and shorten the length of hospital stay. Michael Scotti et al. Saying gastrografin doesn't help. It does not decrease the rate of operative inventions or the number of length of hospital stay, like the number of days in hospital. So when we aim for surgery, what about readmission after surgery because of new adhesions? And when we aim for conservative trial, what about readmission because of the same symptoms again? So I guess this is a topic that has to be discussed in the future, and research is needed there. What we do in USZ, as far as I am concerned, we follow the Bologna guidelines, applying oral contrast when there are no red flags, and observe the patient critically. There's one other marker I want to show you, which can be used for follow-up during conservative trial, which is the procalcitonin. Procalcitonin should have a high value in predicting the failure of conservative management, as Michael Scotti and all found out. Actually, PCT over 0.57 should predict ischemia by 83%, and under this value exclude ischemia by 91%. So now I talked a lot about the mechanical ileus. We're heading to the functional one. which has various reasons as well. It can be refractory because of abdominal or retroperitoneal operations, tumor, bleeding infections, or abdominal trauma, caused by drugs as opioids or neuroleptics, can be metabolic, such as hypokalemia or diabetes mellitus, or vascular in case of low perfusion. And I just want to concentrate due to time on the postoperative ileus. It's also called a temporary standstill, and it's a very frequent complication, so we are very concerned about this topic. The incidence after colorectal surgery is up to 20%. It's completely reversible. It will manifest itself between the 3rd and the 5th day postoperatively, and it has a very high economic relevance due to the prolonged hospital stay. So in 2001, the Ileus concept was established. The Ileus concept is the enhanced recovery after surgery concept, which said that there are 7 measures helping in reducing the length of hospital stay. And actually, meta-analysis on this concept has shown that just chewing of chewing gum, minimal invasive surgery, and postoperative analgesia using PDAs can help and shorten the length of hospital stay. Prokinetics and laxative shouldn't help. Let me finish by take-home messages. Ileus is a very common suspected diagnosis. Surgical expertise is needed in diagnostic and treatment. The sun can sometimes set over an ileus up to 3 to 5 times. We have to rule out the red flags, peritonitis, ischemia, and strangulation before we head for conservative treatment. And adhesion are the most common cause of small bowel obstruction and a relevant problem in daily clinical practice. And chewing gum, minimal invasive surgery, and PDA can save money in preventing a postoperative ileus. Thank you very much for your attention. Now I'm ready for questions and discussion.
Kito, thank you very much for this very nice overview, short time for a pretty complex and many issue related to this ileus. First, what I think it's important is the consequence also of surgeries. Often or sometimes it's done in the middle of the night with people with less experience, and then you induce a fistula while you do the adhesiolysis, and the life of the patient is complicated for months, years, or forever. So I think it's very important. Number one, the indication for surgery must be done with experienced surgeon, and to surgery also because taking out adhesion can be very complex and lead to complications and very poor quality of life later on. Gastrografin was a paper and a discussion at European Surgical, I think 2 or 3 years ago, concluding that please never use it. And maybe I know here use it. We don't have here a absolute rule that we should never use it. Some use it. I'm pretty conservative. Maybe I will ask one of the senior surgeons like Professor Turina to comment on the use of gastrografin. There is also risk and pain, etc. We've seen also a few disasters. Now, over many years, the question was how to prevent that. We were doing open surgery, it's true, with minimally invasive. This is probably one of the major advantage of minimally invasive surgery to have that, as many companies and different things that came with different products. And as far as I know, nothing has ever reached convincing evidence that is useful except to have careful surgery, as you mentioned. You have peritonitis or whatever, bleeding, all that is associated with increased risk. So I think quality of surgery means less adhesion, but we always, like appendectomy, this adhesion. So maybe just, I don't know if Matthias wants to give us his perspective on the gastrografin or whether we should use something else.
Thank you, Janina, excellent presentation. I really enjoyed it. Regarding gastrografin, it is true we quite frequently use it. I must say though, for me the use of gastrografin more relates to its diagnostic value. Is when giving gastrografin we have a chance of doing conventional X-ray images, which will help us distinguish between patients where we will eventually establish stool passage and those where we may not be able to do so. I have 2 other comments. One relates to the use of the word ileus. I think one has to be careful when looking at the English literature, especially the American one. The term ileus is more or less reserved for paralysis of sections of bowel, whereas the term obstruction is used for what we call mechanical ileus or obstruction in the German language. So when you come across the American literature, ileus really means paralysis whereas obstruction means a mechanical problem, except for certain exceptions to this rule, which may be gallstone ileus, for example. And finally, the use of conventional or conservative treatment for mechanical obstruction. I fully agree with the statements that you have made. I think they're absolutely correct, and that's what the literature shows. The one word of caution that I just have is the red flags that you have shown. Sometimes one gets the feeling that the small bowel obstruction has become a standard indication for conservative treatment, and I think that should not be. There is patients with red flags, and they do not benefit from conservative management. And that's quite the opposite. When you have a patient with red flags and you let him lie for 48 hours, he will get worse. And eventually, when you do your operation, you will do it on a patient who is in worse condition. So whenever there are red flags present, then you should operate. Maybe not in the middle of the night, but sooner rather than later. Thank you.
Thank you. Very nice presentation. I have a question also regarding the red flags, but also to the clinic. Because sometimes we have, the strangulation is not so easy to detect. It might be a red flag, but it's on the CT scan, it might not be so evident. You can have indirect signs. You might have a small bowel feces sign, but what's the role of the clinic? If you have someone that is not in emergent pain, would the clinic be more important than the red flags on CT scan or not?
From literature, if you see the guidelines, if you have the red flags, you have to evaluate the patient because had he operations before. So are there risk factors for adhesions, which you see in the CT scan perhaps, and if you have the suspicion that there is a lot of adhesions and you have the red flags in the CT scan, the patient has a lot of pain, you go for surgery, I think. But if you have the red flags, the patient is in a very good condition, you have no white blood cells, no CRP, perhaps you can also wait. Perhaps you have the red flags and the patient is in a very good condition, you can wait, I think.
Okay, good. Thank you.
Okay.